Good evening and welcome everybody to the Tumor Board on Triple Negative Breast Cancer. Here we will be focusing on the different issues in the management of triple negative breast cancer in our day-to-day clinical practice. My gratitude to the organizer for giving me the opportunity to be the moderator. And I'm having outstanding panel members. Let me introduce my panel members. So Dr. Peter Smith, medical oncologist from UK, Dr. K. Gobind Babu, medical oncologist from India, Dr. Sheikh Farid Ahmed, surgical oncologist from UK, Dr. John Conibeer, clinical oncologist from UK, Dr. A.F.M. Anwar Hussain, surgical oncologist from Bangladesh, Dr. Parveen Akhtar Banu, radiation oncologist from Bangladesh, and Dr. Nazrina Khatun, medical oncologist from Bangladesh. Is everybody here?
I think Peter left us, and John will join. Other than
I'm here actually. Hello.
Yeah, John is here. John is here.
So,
welcome, John.
Good afternoon.
Hi.
Okay, good
John.
afternoon.
Welcome.
Hi, John. Okay, let's get started with the case scenario. A 37-year lady presents with left breast lump, approximately 3 into 2.5 cm with palpable mobile axillary lymph node. Bilateral diagnostic mammogram and ultrasonography of both breasts confirm the finding. So core biopsy reveals invasive ductal carcinoma grade 2 and FNS of axillary lymph node shows metastatic duct cell carcinoma. Immunohistochemistry shows ER negative, PR negative, and HER2 negative, that is triple negative breast cancer with Ki67 18%. So the patient falls and clinical stage T2N1, that is a stage 2B. She is asymptomatic and has no comorbidity. She has family history of breast cancer of maternal aunt, and she's very keen for breast conservation. So I'm starting with the surgeon, Dr. A.F.M. Anwar Hussain. Sir, are you here?
Yeah, thank you.
Yes. So my first question to you, would you like to advise any staging investigation for this patient?
First of all, thank you, organizer, for giving me the opportunity to join in this virtual program on breast cancer, and also thanks to Oncology Club. Regarding this question, because it's a triple negative breast cancer and simultaneously the lesion is also identified in the axillary lymph node. So a staging investigation needed in this case, other than ultrasonography and mammography. I should go for CT scan of the chest, abdomen, and pelvis.
Okay. So the patient is asymptomatic and she is in early stage, but she has a risk factor that this is an aggressive histology. So for that, you want to do that investigations, right?
Yeah. Because TNBC is a very biologically aggressive and highly proliferative and very worse prognosis. And there is chance of local recurrence and distant metastasis, even though it is in the early stage.
So there is no recommendation of staging investigation in asymptomatic patients breast cancer, but there in SMO guideline, they have recommended that if there is aggressive histology, then you can go for staging like CT scan, chest or abdomen with contrast or bone scan. So my second question is TNBC a contraindication of breast conservation surgery? We know it's an aggressive disease. It might come back. So is it a concern to you?
No, there is no contraindication like this. There is no contraindication in the form that is TNBC. In TNBC, BCS cannot be done. This type of contraindication is not yet found in any journal or any textbook. But still then, before doing this surgery, one should consult with or counseling with the patient and also place the patient in MDT. Because multidisciplinary team approach is needed in case of at least TNBC and also in HER2 positive breast cancer. These two groups of patients are very much aggressive.
You are right, sir. The evidence says that breast conservation therapy achieves the locoregional outcomes comparable to mastectomy in TNBC. So my third question to you, how would you proceed? Would you go for upfront surgery, then adjuvant chemotherapy and adjuvant radiotherapy, or you'd like to offer NSCT, then surgery and adjuvant radiotherapy?
The scenario which we have seen, in this case, we should start neoadjuvant chemotherapy. Then go for assessment for next step in the form of surgical intervention.
Okay. So, sir, if you go for NS6 and cost involved, and you have the issues of post-NSCT margin status also, then how much you should excise. So even though you prefer NSCT, so this is great. Okay. So now I'm switching to Dr. Farid. So Dr. Farid, are you here? Dr. Farid?
Yes, yes, thank you.
Yes. So are you agree with the decision of Dr. A.F. Manwar Hussain that NSCT should be offered first?
Well, I do agree most of his comments. First of all, just aggressive tumor biology is not an indication for staging investigations. That is one thing what we know. But when we think about any patient, we're planning for a neoadjuvant chemotherapy, it is a standard practice to do staging investigations, which involves the CT, chest, abdomen, pelvis, alongside whole body bone scan. Or if you got a better facilities, you might want to just do a PET scan. So it's a choice. But we like to do the first one, as I mentioned, as a part of workup for neoadjuvant chemo. So in that perspective, my answer is indirectly yes, that is a yes. But not just because the TNBC I would just blindly stage, even if patient has got no evidence of any distant metastasis like axillary node mets confirmed on FNSU or core, I would stage this patient. And the question, is it for me, the BRCA mutation test for this patient?
Yeah, I'm coming,
yeah.
Sir, I'm coming.
Okay.
So now we have understood that instead of staging, you are taking your surgical decision based on tumor biology, right?
That is one of the
as
important
it is
factors to decide.
TNBC. So yeah. So now my question: would you recommend BRCA mutation test for this patient? And
That's
how
correct.
would the result influence your surgical decision making?
Thank you. This is a very important part of TNBC patient management. It used to be age 50, but in fact now up to age 60, age group patients, if anybody diagnosed with a TNBC, triple negative breast cancer, we would recommend genetic testing, BRCA1, BRCA2. In Bangladesh, in fact, I also add TP53 because I've seen quite a few patients there already in my limited years of practice. Now, the difference it makes is most of the TNBC patients, if they're fit and well, we recommend for neoadjuvant chemo, and that allows us the time. We buy that time to do get further information like BRCA testing, genetic testing, and in UK it takes about few weeks to few months for results to come through. But by the time patient is already going through chemos, and if somebody is booked for neoadjuvant chemo, we like to get the staging investigations just for the workup for chemotherapy planning. And we also like to get an MRI of the breast, and post neoadjuvant chemo, we get an MRI to see the comparison. Now, coming back to the specific question, BRCA, if patient is found to be BRCA mutation positive with a pathological variant, we would consult with patient again post chemo. Patient will come back to us. We give them options that there is a high risk of contralateral breast cancer, and we tend to offer bilateral mastectomy and immediate reconstruction depending on the response. Usually TNBC patients, in our experience, they have excellent clinical radiological response, and post-operatively we found a good percentage of patients with complete pathological response. I've seen both in UK and in Bangladesh. And I would definitely change my surgical plan, moderate my surgical plan, and I would consult this with the patient and assess the suitability to go ahead with bilateral surgery and reconstruction if they're found to be genetic mutation.
Yeah. So at this point, I'd like to ask Dr. John. John, you are here?
I am, yes. Hello.
John? Yeah. So I would like to ask you, do you have any reservation to give whole breast radiotherapy to a young patient with a BRCA1 mutation? Would it increase the chance of a likelihood of second primary the treated breast? John?
I didn't catch that question, sorry, but if the question was, would I be happy to give whole breast radiotherapy? Yes, I would. So if the patients had breast conserving surgery, then I would normally recommend the patient for post-surgical whole breast radiotherapy. And I'd also consider them, so they're just on the border of age in terms of a boost to the tumor bed, but depending on the post-op features, I may also consider giving a focal boost to the tumor bed.
I wanted to know the patient is BRCA mutated. So is it the radiation exposure would increase the chance of the second primary in the same breast? Are you concerned with that as a radiation oncologist?
No, I wouldn't be.
Okay. So, Dr. Farid, I would like to ask you another question. I know you have all the facilities and cost is not an issue. So, do you do a PET CT in an early breast cancer patient?
No.
For a staging purpose?
Just because somebody has got money, I wouldn't go for that, because that is not the first line investigations we recommend. We would like to stick to basic CT test, abdomen, pelvis, and a bone scan combination. If somebody needs to have a neoadjuvant chemotherapy, that is part of the staging we like to do, but not just because of a TNBC itself. I wouldn't recommend just based on that to stage.
I couldn't get a receipt, could I?
So we should not offer PET CT even it is free. No, this is the message. Okay. Now I'm coming to Dr. John again, as Peter is not there. So, Dr. John, is all TNBC always the bad news? Because when a TNBC patient comes to us, we are calling it as an aggressive disease and we're scared of it. But do you think that all TNBC is act in the same aggressive manner? John? Okay, can I ask this question to Professor Gobind Babu, sir?
Yeah, thank you very much for having me here. If I
let me tell you something, sir. Sir, happy Diwali, sir.
Oh, thank you very much. Thank you.
And we are really grateful that you people are giving us time on your festive days.
No.
Thank you so much, sir.
Every day is a festival. You see, it depends on how you see it.
yeah. But this is the Diwali day. So thank you, sir. This question, can you take this question, sir?
Yeah, sure. So
I'm back, actually. I'm back. So is triple negative always bad news? So whenever you meet a patient who's been diagnosed with early breast cancer, it's always a case of breaking bad news. So having cancer is not good. In terms of the phenotype of the cancer they have, so triple negative breast cancer, when I speak to them about it, I think that the bad news in terms of the treatments, obviously they have a more limited number of treatments because they don't have access, for instance, to adjuvant endocrine therapies. And historically, the responses we sometimes see to standard of care chemotherapy is less effective. Having said that, with the advent of immunotherapy and the improvements it seems to bring to the clinical study we've seen so far, obviously there's new developments in the field which is improving outcomes for these patients. But I wouldn't strictly consider it always as bad news. I think it's the type of breast cancer, because of the more limited treatment options, that you don't want your patients to have if possible. And in terms of should all triple negative be treated in the same aggressive manner, I think you have to base your treatments on not just the breast cancer, but also the patient's comorbidities, physical fitness. And so obviously you can't give immunotherapy and chemo to all neoadjuvant triple negative breast cancer patients, because some of them will themselves have autoimmune conditions which precludes the use of immunotherapy. So when you have your patients presented at MDTs, you need to create the bespoke treatments for those patients that matches their tumor characteristics, but also their personal circumstances as well. I hope that answers it.
Okay. Now, we know triple negative breast cancer is a heterogeneous disease. There are some subtypes which have a good prognosis and subtypes which have a very bad prognosis. For this, I'm asking you this question that triple negative is not always a bad news. There are some good prognosis triple negative also, that is the medullary, apocrine, and adenoid cystic. So I think we should not generalize the data. We should not treat all the triple negative patient in the same aggressive manner. That is, a IDC high grade should not be treated like a medullary carcinoma, which is TNBC. So their treatment plan should be different. Is it right, John?
That's right. So again, our standard of care would be to discuss all the patients with triple negative breast cancer in a multidisciplinary meeting to make sure that we're selecting the most appropriate treatment for their subtype. So yes, that's right.
Yeah. So now I'm coming to Dr. Parveen, madam. Ma'am, you are here. Are you here?
Yes. Hi, everybody.
So now this patient is referred to you with the decision of MSCT. So which CT regimen would you like to offer?
Yeah, thank you for keeping me as a panelist. As we know that triple negative breast cancer is heterogeneous, and all triple negative breast cancer are not the same. And more and more we are offering neoadjuvant chemotherapy to triple negative breast cancer because in this way we can see the response of chemotherapy, and also in the meantime we can decide our next step, do the genetic testing, BRCA mutation, and more. We know more and more from different studies, we know that PET-CR is important for disease-free survival and overall survival. So neoadjuvant chemotherapy, I would like to give this patient to start with dose-dense AC followed by paclitaxel every 2 weekly or every 3 weekly, AC followed by paclitaxel or AC followed by docetaxel. Paclitaxel weekly is preferable than 3 weekly, and AC followed by 3 weekly docetaxel or TAC regimen. There are several regimens we can choose from there depending on the patient's ability and suitability.
Okay, perfect, ma'am. How many cycles would you like to go before surgery?
I will like to complete my chemotherapy cycles, 4 cycle AC followed by Pacli or Dosi, and see, and then I will refer the patient to surgeon for surgery.
So I will come back to you later on. So now I'm switching to Govind sir.
Yeah, thank you for having me again. And I think the slide you showed about the heterogeneity of triple negative is a wonderful slide. So you need to keep that in mind. At our center, we are actually doing, as a part of the workup, the AR status also. So we have found that positive in about 12% of our patients. We are not using to target it right now, but this is a part of our protocol. So coming back to your patient, her Ki67 is only 18%. So although she's triple negative, I won't think that she's got a very aggressive disease, but considering her age, I think it is worthwhile that we should give her neoadjuvant chemotherapy, because it's also a window of opportunity for us to look at the tumor after the neoadjuvant chemotherapy is given. So definitely neoadjuvant chemotherapy for her. And if we find out that she is BRCA mutated, like you said she is, then I would prefer to use a platinum, because then the response rates, including a pathological complete response, is much higher when we use platinum compounds. So that is how I would tailor if she is BRCA mutated. Otherwise, as Dr. Parveen said, it will be the standard chemotherapy. The other thing that we are doing, what we are doing is, we are not waiting to complete the full cycles of neoadjuvant chemotherapy. We are assessing clinically after every cycle, and as and when we feel, maybe most of the time between 3 and 4 cycles, we take them up for surgery. That is our present protocol, because we want to look at the tumor that is there. So we don't complete the whole neoadjuvant chemotherapy before surgery, but that is the standard practice always. So this is what we are doing.
Can I ask a question to Professor Govinda?
Yes, yes.
So you don't insert a marker clip prior commencing neoadjuvant chemo, because these are the basic.
Of course. Yes.
Then what's the point? What's the point doing a sandwich chemo? Because you should be completing the chemotherapy, and then if there is a complete response, you do a wire-guided wide local excision following that marker clip.
Yeah, we are trying to look at it as a window of opportunity to look at the tumor characteristics once it becomes operable. That is the only thing. Otherwise, it is always finish the complete neoadjuvant chemotherapy and then look at surgery. Yes, I agree with you.
So, sir, in your clinical practice, do you offer every TNBC patient in a city or some selected patient?
For triple negative, by and large, we offer everybody. And this is our MDT protocol that we follow. By and large, yes. Unless it is such a small tumor where the surgeon says, no, I will do surgery now. Otherwise, most of them will go.
Okay. So then why this NACT, sir? What is the goal in such case of giving this NACT?
Yeah, like I told you, if we have a complete pathological response, then it is a surrogate for the overall survival. So it is like a window of opportunity that I'm looking at when I give neoadjuvant chemotherapy. And not just in TNBC, in many operable breast cancers, neoadjuvant chemotherapy is becoming sort of a standard of care.
Yes. So you are taking the PCR as a surrogate markers for overall survival. And do you consider it as an indicator to figure out the high-risk patient to escalate our therapy?
No, right now we are not doing any of that. No.
Okay. So, sir, is there any difference in survival or long-term outcome whether we give the chemotherapy adjuvant or neoadjuvant?
No, there is no difference. There is no difference. It's only that if you have a pathological complete response, it is an indicator for the overall survival to be better. Whether you give neoadjuvant or adjuvant, the outcome is very similar.
That's right, sir. So this is what you said, that overall survival and PCR has a very good correlation. The patient having PET-CR have a very better outcome comparing with those patients who didn't show a complete pathological response. So, sir, I would like to ask you some question. Wonderful novel agents are coming up, but in our context, chemotherapy is still the only weapon for us to fight with. So I want you to address the issues regarding the chemotherapy so that we can intensify or we can get the maximum benefit of chemotherapy, even of choice in your setting. So the same portion, I think I repeat the same question.
Yeah. So I've already finished the role of platinum.
Yeah.
And I've already told you the number of cycles of chemotherapy. The standard practice is finish your neoadjuvant chemotherapy and then take for surgery. But as a part of protocol, we are doing this as a study. Nab-paclitaxel is said to be better because of various reasons. So, and we have a lot of generic nab-paclitaxels in India, which are very affordable, which are as much as the regular paclitaxel. So we tend to use nab-paclitaxel. There is still a controversy about dose-dense chemotherapy. Some people prefer to use, but then you look at a patient, whether the patient can tolerate dose-dense. And then because your responses, a pathological complete response, are better when you give dose-dense. If your patient is fit to take, then definitely give dose-dense. And you can use TAC, you can use AC followed by taxane, whatever you're comfortable with. But again, since you're looking at complete pathological response, maybe TAC would be a preferable option because you're giving all the chemotherapy upfront. But you can choose what you want. The best thing is what you are comfortable with. You don't change your protocol for each patient. If you're comfortable with one regime, follow that for all your patients, because there's so many things that you're used to when you're giving these chemotherapy drugs. So I would definitely advise you to follow the same protocol. You can make minor changes, but don't use TAC for one patient, don't use AC followed by docetaxel for one patient. That would not be the ideal thing to do.
So some patient with poor general condition or cardiac comorbidities, can we offer them some non-entra regimens like CMF or DC, that is docetaxel and cyclophosphamide?
Now, if the left ventricular ejection fraction is good, then you can go ahead with anthracycline. There is no need to avoid anthracycline. So you need to look at the left ventricle.
The cardiac comorbidity, yes, is the ejection fraction is not that good?
Yeah, then you avoid anthracycline.
Give
Yes.
non-entra.
Yes, yes. So you have a choice of platinum with taxane. So that will be the good one for you, because then you're looking at a good pathological complete response in your TNBC.
So, sir, right now you are using platinum with your ACT protocol, right? We
are using only for BRCA mutated, not for everybody.
Not for everybody. Yes, sir. According to the existing guideline, they are not recommending platinum for every patient. They recommend it for a subset of patients when you need a rapid response. So, which of those subset of patients where you would like
your voice is breaking.
Yeah, like I said, I'm using it only for BRCA mutated patients, not everybody.
Just only for BRCA mutated
yes,
patients.
That's
not,
right.
The aggressive breast cancer patient. Would you like to add this carboplatin with taxane and anthracycline chemotherapy?
No. Only for triple negative I'm using, not for any other subset.
So there is a meta-analysis that showed that dose chemotherapy has a better outcome, that is in terms of disease-free and overall survival than conventional genomic chemotherapy. And about the platinum, sir has already mentioned that there is 9 RCTs that looked at the effect of platinum or adding platinum with our conventional chemotherapy, and it showed that in this PET form, 39%, that is with ACNG, to 52.1% by adding carboplatin. So I think that we should confidently use carboplatin for our patient. So now I'd like to ask Dr. Nasrina. Dr. Nasrina, are you here?
Dr. Shahida, your voice is breaking. I think there is some problem in your network.
I think you have some internet connection problem. Okay, proceed. Please proceed.
Yeah, please proceed. Dr. Shahida, you can proceed.
So, can you hear me, Dr. Nasrina?
Yeah, we can hear you, but the voice is breaking, but you can proceed.
Yes. Just
I am here.
Yeah.
Lima, we have only 25 minutes left. We need to be fast.
Dr. Shahida, could you please share your screen?
He has disconnected the device. Better connect.
Sorry, we have some technical issues. Dr. Shahida is disconnected. So before joining of Dr. Shahida, Dr. Govind Babu sir can tell something about the neoadjuvant treatment of this triple negative breast cancer.
Yeah, like I already mentioned, we use the standard for all breast cancers, irrespective of whether it's triple negative or otherwise, except in BRCA mutated. Only there I use platinum as one of the part of chemotherapy. Otherwise, it is the same chemotherapy that we use. And like I already mentioned, giving neoadjuvant chemotherapy is a window of opportunity for me to study the response to the tumor. And we just started a project on looking at the proteomics. So we are trying to see if we get a proteomic signature and we can correlate it with the responses that we see with chemotherapy. That's a project which we've just started. The other one we are doing is looking at circulating tumor cells. So we just published that last year. We are trying to see in how we are making changes in the circulating tumor cells with chemotherapy and whether that can correlate with survival. So those are the two things that we are doing. I think Dr. Shahida is back.
Yeah. Sorry for
share the screen.
A bit fast because you don't have much time in hand. Only 20 minutes left, please.
Okay. So now I'm coming to Dr. Nazrina, ma'am. So I know you have been using carboplatin with the standard regimen for a few years for TNBC patients. So I'd like to know what is your experience. Are you getting a higher proportion of grade 2-3 hematological toxicities? Dr. Nazrina?
Am I audible? Hello?
Dr. Nazrina?
Yes, Dr. Nazrina, you are audible. You can say.
Thank you, Dr. Shahida.
Dr. Nazrina?
Yeah,
Yes, Dr. Nazrina, you are audible. You can tell.
So, Dr. Nazrina, are you hearing me?
Yes, I am hearing you, and I am audible to other persons.
Yes, you are, but need to talk a bit louder if possible. Okay, please proceed.
I think our patients are well tolerated with carboplatin, though we have limited data. But we observed that few patients, like 5 to 10%, presents with grade 3 or 4 toxicities, but that are manageable with GCSF. Okay, then another thing is our patient, none of the patient discontinue the treatment. We offer those patients, and the patients are not discontinue the treatment. And another thing is no reported toxicity related death till now. So I want to say that the patient complete their scheduled chemotherapy with carboplatin. Thank you.
So we also use carboplatin in Barters with our standard of care chemotherapy. So we use AC carbotaxol weekly. And again, we see improved response rates. And we normally select it for patients with high risk features, grade 3, node positive, triple negative breast cancer.
Lima, proceed, please. Lima, are you there?
Dr. Shahida? No, we are not seeing him.
Yes, come on,
okay.
Yeah, please proceed.
Please proceed.
Yeah, proceed. So,
Nazrina has responded. You can proceed for the next question.
So next question. So can you see my slide? Where is my slide?
Yes, slide is visible.
So the patient receive, where is slide so visible?
Ma'am, can you say the slide number, please? We can proceed. No problem.
You can share the slide for you. Let us share the slide for you.
I think it is. Are you sharing the slide?
For you.
Yes, ma'am. We are sharing the slide.
Which number slide? Go next.
Yeah, next. So this is the question for Dr. Nazrina, and I think she answered the question. She's already answered the question. Okay. So can we offer anything better? As you can see that with ACT, conventional ACT, we have achieved a PAT-CR of about 40%, and then adding carboplatin, it jumped to 50 to 55%. So can we offer anything better to increase its PAT-CR? So this question is to Dr. John Conybeare.
So yeah, based on my colleague's trial results, I consider immunotherapy plus chemotherapy.
Yeah. So should neoadjuvant immunotherapy be the standard of care in 2020 and of course for the affordable patient?
If John is not available, then Govind.
Then Govind Babu, sir, you can take it. Should neoadjuvant immunotherapy be the standard of care in 2020 for affordable patients, sir?
Yeah, with the compelling evidence that we have, I would definitely look at it as a good option, definitely. And 2020 is only 2 months, so going on to 2021 also. So I think the evidence is really compelling, but how we can immediately take is the thing. So I would definitely discuss this with my patient, give all the data that is there, and definitely look at it as an option because we are looking at complete pathological response.
So you are convinced with the existing
data, with the data, yes,
yeah,
yes,
yeah.
Definitely.
So, if you look at the keynote 522, still there is 35% patient who didn't achieve a PAT-CR.
Correct.
So in this era of precision medicine, would you recommend any biomarker testing before offering the immunotherapy? Then who will get the response and who benefit and who will not?
Yeah, so we are using PD-L1, TMB, CPS, but none of them are the best tumor markers. So it depends on what immunotherapy you're using and the companion diagnostics you have to use. That is the only way right now.
So right now there is not the definitive marker for using the immunotherapy, right, sir?
No. For each drug, there is a companion diagnostics, but they are not the ideal biomarkers as of now.
Yeah. For pembrolizumab, there is a PD-L1 positivity is not a prerequisite. So is it significant of doing a PD-L1 before prescribing pembrolizumab?
So it depends on how you look at it. You want to do a biomarker and do it, you have to use the ones that have companion diagnostics. You don't want to do it, then use pembrolizumab.
Okay. Right, sir. So this is the trial that is keynote 522, which is for pembrolizumab in early triple-negative breast cancer. And the case continued. The patient received for NSCT with a dose-dense AC 4 cycle and 2-weekly paclitaxel for 4 cycle. Breast conservation surgery with axillary lymph node dissection up to level 2 was done, and histopathology report revealed ITC grade 2, and there is residual tumor of 0.8 cm with a node negative and margins are free. So this is now the pathological staging is YPT1N0. So sir, what is next for this patient?
So for these patients, we continue to give them capecitabine based on the last study that was presented.
I will come to later on, sir. So now I'd like to go to Dr. John for this issue of radiotherapy. So the patient is advised for adjuvant whole-based radiation. So Dr. John, Do you think that this NSCT PCR have made the radiation oncologist job quite a bit difficult? Because this issue of this regional nodal irradiation, because we'll never know then how many nodes were positive initially. Was it 1 or 3 lymph node positive to make our decision for RNI? Or the post-NSCT tumor bed boost, how to delineate after a complete pathological response?
So in our center, we normally use, if they have residual tumor within their lymph nodes post neoadjuvant chemotherapy, even if it's only one lymph node post neoadjuvant chemo, we will do regional node irradiation. I think you can also be guided by the pre-neoadjuvant staging imaging. So if the patient's had a PET scan, for instance, and it shows that there's FDG-avid disease, subpectoral, internal mammary chain, then again, I would also offer them regional nodal irradiation after treatment because of the bulk of nodal disease. And in terms of whole breast radiotherapy, yeah, I would also consider, as we talked at the very beginning, in terms of the benefits of a tumor bed boost, depending on, for instance, young age, so under the age of 50, the fact she's got triple negative disease. The grade, I think, was grade 2, wasn't it, initially? And so all of these factors play into the decision making behind radiotherapy.
So regarding the fractionation, would you like to give hypofractionation to this patient or conventional fractionation?
So yeah, so in our center again, our standard fractionation for patients with regional node irradiation is 15 fractions. So we normally use 40.05 and 15. If we're not doing regional node irradiation, we'll now apply the fast forward fractionation, so 26 gray and 5 fractions to the whole breast. But if it involves nodal areas, then we don't use that fractionation as it wasn't in the study.
So do you think that triple negative TNBC is an independent risk factor for the decision of radiation in case of a mastectomy patient? It's not for this patient. I would like to ask this question for you, because we have most of in our setting we have mastectomy patient. So all the prognostic factor is favorable, just only patient is young and TNBC. Would you like to give post-mastectomy radiation to this patient?
Not necessarily if it was a very small tumor to begin with, you know. So definitive post-mastectomy radiotherapy, T3 disease, node positive, multifocality, close margins. So if it was a small tumor pre-neoadjuvant chemotherapy node negative, then I wouldn't necessarily just on the basis.
Dr. Shahida, you are requested to go first because we are running behind the time.
So, Dr. Govind, sir, this patient she didn't achieve a complete pathological response. So, should we offer adjuvant capecitabine to this patient?
Yeah, I think that is the data that we have from the last ASCO. So that's what we are following now.
So in your clinical
definitely these patients with the residual tumor, yes, we are offering, yes.
So should all patients not having PCR be offered post-NSCT adjuvant capecitabine? Because then in CREATEX trial, they have shown that not all the subtypes are benefited in the same manner. The vessel,
Since we are not doing all the subtypes, so we are trying to give the benefit to everybody. We don't know who will benefit, but then because there is benefit, you need to give it to everybody.
So as of now, there is no test to
there is no, definitely.
This basal, which one is basal and which one is non-basal? No? Okay.
And you know, we have problems with tolerance of capecitabine. So you have already put metronomic chemotherapy. So that is the other thing that we use for many patients.
So I would like to hear something about this metronomic chemotherapy from you, your experience with, do you use this endoxan and methotrexate?
Yes, yes.
Yeah?
In fact, we use this for metastatic disease also, where many of our patients, sometimes they cannot afford or they finished all lines of chemotherapy. And this has definitely shown to be useful. We've been using it in metastatic breast, lung, cervix, and almost every tumor. So we have had good responses with metronomic chemotherapy.
Okay, so regarding capecitabine, what is should be the dose and duration of treatment in our setting?
We are not using capecitabine for metronomic. It is only
no, not so for metronomic. That is post-anesthetic adjuvant.
Yeah, see, what is advocated is 1 gram, but many of our patients don't tolerate that very well. So we have to make dose adjustments.
Okay.
I don't know how well your patients tolerate this dose.
But if you decrease the dose, do you think that it will compromise the outcome?
Definitely, but the other thing, but the other thing is with toxicity, they will not be taking the drug at all, you know.
Yeah.
So you need to balance between the two.
Yes. So this is the CREATEX trial.
Right.
Okay. So to be honest, sir, in our setting, most of the patients undergo upfront surgery and then they are referred for adjuvant chemotherapy. So my question to you, sir, are we doing too wrong? Is it a significant compromise of the management of patient?
See, there are a lot of surgeons still, even in India, who do modified radical mastectomy and not breast conserving surgery. So, you know, it is our duty as oncologists to spread the awareness, talk to them about all these things that are happening. It'll take time to change because, you know, surgeons were the first people to treat oncology patients. So they believe they're the best. But I think we as oncologists need to tell them because a lot of breast surgery still is done by general surgeons and not oncosurgeons. And they stick to what they were taught and what they're comfortable with. So we need to make conscientious effort to educate them and see that they follow the best for the patient. So we shouldn't be telling that what you're doing is wrong. We should tell them the patient should get the best. That is how I'll put it. Yeah.
So, sir, regarding this adjuvant city, when to start? Is it important for TNBC to start it the duration between the surgery and the initiation of chemotherapy should be not more than 3 to 4 weeks?
Yeah, that is what is there for everybody, not just TNBC. For everybody, we start adjuvant chemotherapy 3 to 4 weeks of surgery.
Okay. Sir, can we add platinum in adjuvant setting?
There is no great data for that.
Yes, right of now there is no
guidelines
are not recommending. But you see in the guideline, the chemo regimen that we use in neoadjuvant chemotherapy, we can use that same protocol in the adjuvant setting, right?
Correct.
So, sir, if I get a patient that is into disease or a large tumor, like 4 to 5 cm young patient, can I at that time add carboplatin with my ACT protocol?
So even there, I will use it only in BRCA mutated patients, not everybody.
Not yet. So, sir, is there any role of adjuvant capecitabine in this case? This is a meta-analysis by Natore and the Siboma trial, not the post-NSCT capecitabine. This is the adjuvant with, sir.
Yeah. I don't think we have any great data for that. Yes. I would still like to use the chemotherapy only as adjuvant.
Okay, so as of now, you are not using this capecitabine.
No, I'm not using capecitabine as adjuvant.
Okay, okay. So regarding the surveillance and follow-up of TNBC patient, though as it is an aggressive disease, it relapses early and more visceral metastasis, is intense follow-up with imaging studies for metastasis screening warranted, sir?
As of now, no.
Yes.
Definitely not.
So the follow-up protocol is same as the other biology.
And talking about your patient, her Ki67 was only 18%, so she's still really not very aggressive, although she's TNBC.
So as if the patient is TNBC, we don't need to just scan her every 3 months or 6 months for metastatic workup.
No, not at all.
Yes, sir. So,
Shahida, I think we can stop somewhere because we have one more session to go. I understand you're moving to metastatic.
Yeah.
If you please allow us.
Should I stop here?
Can you please wrap up? Yes, please.
Okay. So I want to wrap up with one of my favorite quote that don't let the good be the enemy of best. So what we are doing is definitely good, but in oncology, we have to look for the best always. So this is my final message to all, and thank you so much every panelist for your valuable opinion and discussion. We have learned so many things from you, and thanks the audiences for being with us. So it's over to Arman.